Hello, my name is Dr. Bonnie Ky, and I'm an Associate Professor of Medicine and Epidemiology at the University of Pennsylvania, and I'm Editor-in-Chief of JACC, Cardio-Oncology. Today, I have the extraordinary privilege of introducing to you all our inaugural JACC Cardio-Oncology virtual case presentation series. This first series will focus specifically on amyloidosis. Today, I'm joined by a very esteemed panel. I'd like to introduce to all of you Dr. Witteles. He's a professor of medicine at Stanford University. He's a program director of the Internal Medicine Residency Training Program. He's co-director of the Stanford Amyloid Center, and he's also co-director of the Stanford Multidisciplinary Sarcoidosis Program. And I have the great pleasure also of working with Ron as an associate editor of JACC Cardio-Oncology. I'd also like to introduce to all of you Dr. Wilson Gonsalves. He's an assistant professor of medicine and oncology, a member of the Myeloma, Amyloid, and Dysproteinemias Disease Group at the Mayo Clinic in Rochester, Minnesota. And of course, last but not least, Dr. Rola Khedraki. She's Chief Cardiology Fellow at Scripps Clinic in La Jolla, California. She will be starting an Advanced Heart Failure and Transplant Fellowship at Cleveland Clinic come this July, and boy, are they lucky to have her. Dr. Khedraki, I understand you have prepared for us two very interesting and informative cases. I'll let you, Dr. Witteles and Dr. Gonsalves, take the lead on this, and I look forward to all the learning and teaching for the next 30 to 40 minutes.
So the first case is that of an 84-year-old male with history of ischemic cardiomyopathy, EF of 25%, and he's been followed by his outpatient cardiologist for several years. And over the past couple of years, he's been having repeat heart failure admissions, and so he's referred to heart failure clinic for further evaluation. His past medical history includes chronic atrial fibrillation, hypertension, and CKD stage 2. And although he's had a history of hypertension, more recently, he's been having low blood pressure that's really limited his ability to be on guideline-directed heart failure medical therapy. And so he started on midodrine for orthostasis. And also of note, he has a history of spinal stenosis, and this has been worsening also over the past couple of years with neuropathy. And this is his EKG at the time of his visit to the heart failure clinic. So maybe we can pause here and if the panelists have any comments so far on this case.
Yeah, hi, Rola. Thanks for that. I'm not sure. Perfect. Now I see the EKG. Well, I'd say, first off, it's really unusual to have somebody in their mid-80s suddenly who has a history of hypertension, suddenly have so much hypotension that they actually need to get on midodrine and presumably come off their hormonal antagonist. That should be a little bit of a red flag. Obviously, we have a case discussion on amyloidosis, so that's going to be on our minds. But I would say should be a red flag to think about something that's going on. The spinal stenosis is another red flag, obviously not uncommon in older individuals. Particularly for transthyretin amyloidosis, often runs in similar circles. And then if we look at the electrocardiogram, of course, we see inferior waves. Now, this is a patient who has a known ischemic cardiomyopathy, so it may be from an old inferior infarct, but if not, one has to think about other potential causes of Q waves. You'll note, because we are having a case discussion of amyloidosis, that the voltages here are normal. They are not low, and that is a often misconception about amyloidosis that you have to have or typically have low electrical voltages. So he has a right bundle branch block, he has inferior Q waves, and he has atrial fibrillation, which sounds like it's chronic.
Yeah, that's right. This is his echo, both the parasternal long and 4-chamber view. And you can see that he's got marked thickening, biatrial enlargement, even valvular thickening. And someone who has had long-standing hypertension, sometimes people tend to think, oh, this might just be from the hypertension itself, or the biatrial enlargement.
I think we lost Rola for a second, so I will jump in and agree wholeheartedly with Rola's point that typically people will see LVH and just sort of shrug it off because of the history of hypertension. You know, everyone in their 80s has a history of hypertension, certainly pretty much everybody with ischemic disease. So you have to differentiate between a typical hypertensive looking heart and something more sinister. And this certainly looks like something more sinister. The quote unquote hypertrophy, it's really not hypertrophy, but increased wall thickness is quite marked here. You also see that it's biventricular. The RV is clearly thick as well. I would say an echo like this should set off some red flags.
Yeah, absolutely. Lots of red flags, symptoms, and then corroborating here with the echo. And this is his strain pattern. You can see sort of the characteristic cherry on top appearance with the apical sparing. So what would you do next at this point as far as your workup?
Sure. So I would obviously be concerned about amyloidosis, and the algorithm of how to proceed here is really quite straightforward, and it was included in a review article that Michaela Leakey, is a hematologist at Stanford, and I co-authored in the first issue, first volume of JACC Cardio-Oncology. So the algorithm's straightforward. You want to first rule out a monoclonal protein to make sure that you don't need to be concerned about AL amyloidosis. And that's done with 3 tests: a serum and urine protein electrophoresis with immunofixation, and a serum-free light chain assay. If those are all normal, then you can move on to the next step, which we might get to, which would be a technetium pyrophosphate scan. If abnormal, we need to move on to biopsy.
Yeah, absolutely. So, you know, that's what we proceeded with here. We sort of concomitantly got the pyrophosphate scan and the SPEP and free light chain. So we'll go through those. You can see the planar and SPECT images here showing moderate tracer uptake in the LV. And maybe Dr. Witteles, do you want to comment on sort of the specificity of this for, you know, guiding you one way or the other?
Sure. So for those who aren't familiar with this, this is a bone scintigraphy scan. So this is in the United States, we use technetium pyrophosphate. There's other tracers that are used in other parts of the world. And it turns out that such tracers are taken up by hearts infiltrated, particularly with transthyretin amyloid deposits. So what you can see on the planar images is you see the heart lighting up. In fact, for a bone tracer, the heart, if anything, looks darker than the bone. So that's a very positive scan. But you always want to look at the SPECT images as well, make sure you're not getting fooled by blood pooling. And you can see on the SPECT images the clear outline of the heart. So this is a very abnormal scan, a very positive scan. But I really want to emphasize that this has to be done only after, or at least in conjunction with, that ruling out of a monoclonal protein. So from the manuscript, which really solidified the technetium pyrophosphate's place in the algorithm, which was by Gilmore and colleagues in Circulation in 2016 of over 1,200 patients, there was a 22% of the patients with AL amyloidosis had positive scans with significant uptake, what we'd call grade 2 or grade 3 scans. So you cannot use this to make a diagnosis of transthyretin amyloidosis without ruling out a monoclonal protein. However, if you do rule out a monoclonal protein and have a positive scan, in that study, 391 out of 391 patients were correctly diagnosed with transthyretin amyloidosis. So it is the way to use the scan and can save people a biopsy.
Ron and Rola, I'd just like to pause for a moment just to clarify a point. Ron, you noted quote unquote sinister hypertension. Tell us, at what threshold of LVH do you typically start screening or thinking about screening for amyloidosis?
Yeah, thanks, Bonnie. You know, so myself and colleagues published an article in JACC Heart Failure last year with this question of who should we screen? And I will be clear on this, that this is opinion-based, not yet really strong evidence-based, because but this is what our working group came up with. So characteristics of a good screening test need three things. Number one, a high enough prevalence of the condition in the population being screened. Number two, that there's an accurate and preferably non-invasive test that's easily available. And number three, if you make the diagnosis, you have an effective therapy. Well, I would say for transthyretin amyloidosis, we've certainly now have an accurate and non-invasive test, as we see right here. We have effective treatments, not a cure, but effective, at least one effective treatment if a diagnosis is made. So the question is, what's the right population with a high enough prevalence? We have a sense, we don't know for sure, but our sense from our working group is, given how easy it is these days to make the diagnosis, and given the impact of the therapy we have, that we should actually be more broad in terms of who we screen. So we came up with that if you have a wall thickness of at least 14 millimeters, and you're a man above 65 or a woman above 70, and you have either heart failure or any red flag symptom, things like carpal tunnel syndrome, spinal stenosis, et cetera, that should trigger a workup. And that you basically throw out the hypertension part of it. Because again, everybody's hypertensive just about as you get into an older age range. And if you are going to say, well, we're only going to count people who don't have a history of hypertension, you're going to miss the vast majority. So that's the threshold we came up with. Wilson, I'm curious, do you know at your institution how you decide?
Yes, Ron, thank you. No, exactly. I think the approach we take mirrors exactly what you have mentioned. People who definitely have on the echocardiogram a wall thickness. There's no absolute number that people, but a wall thickness closer to 15 millimeters or 14 millimeters, I think should really clue you on, especially if they come in with a history of bilateral carpal tunnel syndrome. Just like this patient, they have a history of spinal stenosis. Those are all things that should at least warrant. If I see that patient in the clinic, that's an immediate call to at least my cardiac amyloid colleagues to see whether they would be able to see this patient.
Thank you for these excellent teaching points. And I just want to drive home the point that if one is suspicious for amyloidosis, the first test that one should obtain is electrophoresis and the free light chains assay. Correct, Ron? Tell us a little bit more about this. I mean, oftentimes people will jump to imaging tests as the first diagnostic test of choice, but tell us why it's so important that one obtains the electrophoresis and the free light chains.
And that's right. And for the reasons that, again, this test is the PYP scan is uninterpretable unless you have ruled out a monoclonal protein, but also the urgency of it. That the urgency of making a transthyretin diagnosis is not the same as making an AL diagnosis, because the AL patients can gallop along very quickly in terms of their disease course if you don't get them started on therapy. Transthyretin is always going to be slower. So when you see a patient who you're suspecting amyloidosis, the first thing you must do is satisfactorily rule out AL amyloidosis.
Perfect. Thank you.
One other point I've seen in clinical practice with these consultations is that new onset atrial fibrillation that they went to their local emergency room, and just like clockwork, they started them on rate controlling medications, just poor tolerability to rate controlling medications on that. That I would say is something we routinely see, especially in this population.
Thank you for that. You guys highlighted exactly the point that I was trying to get at here, and we'll see why as we progress through this case. So here's his SPEP, to the point of the importance of ruling out a monoclonal protein. He doesn't, in fact, have a monoclonal protein, and the immunofixation shows that it's an IgG kappa monoclonal gammopathy. The UPEP did not show any monoclonal proteins here. So how does this sort of fit into your algorithm now?
Well, so as stated before, you can no longer use that PYP scan to make a diagnosis. And now, look, he's a man who's 84 years old. It is not very uncommon to have a monoclonal protein production. We know monoclonal gammopathy of undetermined significance becomes more common as you get older. However, this now raises the question, maybe he has AL amyloidosis, and we're going to have to move on to the next steps. Wilson, this is right in your wheelhouse. How would you look at this?
Yeah, no, I think you're absolutely correct. I mean, once you find this monoclonal gammopathy, if I'm seeing him in clinic, it's my goal, my objective for that visit is how do I make sure that this monoclonal protein is not the protein that's misfolding and forming AL amyloid deposits. So it's important to note that if you just take, and we've looked at this in a population, you just take patients who truly have wild type TTR cardiac amyloid, about almost a fourth of them would have a monoclonal gammopathy. And it just goes hand in hand, as Ron said, as you get older, your risk of getting a monoclonal gammopathy increases. I always like to give the example that most people walking down 2nd Street, which is our down street here, who are 50 and older, about roughly 5 out of 100 of them would probably have a monoclonal gammopathy and not know about it. But once you find it, it's really important, just because the stakes are so high for missing an AL amyloid case here, that we start working this up on. And so I see here the serum protein electrophoresis. Well, here it's a little easier because they have a monoclonal protein of 1.2 grams per deciliter. That's an IgG kappa. Now, just one additional point, because sometimes you see this in the outside where people will get the serum protein electrophoresis, and it depends on where you practice. Like most institutions where if you're using an Epic software, everything's bundled together. So you order the SPEP, it automatically reflexes an immunofixation. Just remember that's not always the case outside. So people will get an SPEP and you order an immunofixation. It's a full separate other order that you have to add on to it. But you really want an SPEP with an immunofixation, because at times the monoclonal protein can be quite small in size, that the SPEP will be read as normal. And remember, these are really being visualized and interpreting it. So you can miss very small amounts of proteins if you don't get the immunofixation on. And the same thing for the urine protein electrophoresis. You should get really a 24-hour urine protein, do the electrophoresis on it with an immunofixation. And finally, just add the last part. I don't know if there were light chains added to this monoclonal protein assessment. Oh, there you go. Okay. So, here you can see there's a kappa-free light chain level that's elevated, lambda-free light chain that's elevated, but the ratio is normal. My guess is this would probably fit a little bit with the fact, I think you mentioned that the patient had CKD2 or so on. So that probably, just that reduced GFR probably makes some of these levels look higher than the typical range.
That's right. I included labs here, including his creatinine, to sort of discuss that point as well, that it could just be from the CKD itself.
Right. And just to comment on these overall labs, so we see first of all a troponin that probably, depending on your lab's reference range, I suspect may either fall in detectable but normal, or frankly abnormal, but at the very least is detectable, and clearly in a significant elevation in the NT-proBNP. The point that Wilson was making about the free light chains is really important. So in just about anybody with significant kidney disease, you'll see elevations in both the kappa and the lambda, because the kidneys are one of the two main systems for clearing light chains. So that was a normal free light chain ratio, meaning one of two things. Either A, this person's presumed plasma cell dyscrasia is producing really just about only whole immunoglobulins and not the light chains, or that it actually is producing light chains, but the light chains are so prone to deposits that they all deposit as amyloid deposits very quickly, and we don't actually see as much of them in the serum. Though the free light chain ratio is normal, the presence of an abnormal spike on the serum protein electrophoresis with immunofixation says, again, you have to move on to the next step to rule out AL amyloidosis here.
Yeah, absolutely. That's perfect. Even though the ratio, again, the ratio is normal, but we still have this monoclonal protein on the SPEP. So the next step, we moved on to a bone marrow biopsy, which showed that he has a plasma cell myeloma comprising 10 to 15% of the marrow. The immunohistochemistry showed that these cells expressed CD138 and kappa light chain, and the flow cytometry showed that they were CD45 negative, again with this kappa light chain predominance in a small population with CD56 positive plasma cells. And the FISH showed duplication of 1q21. So how do you interpret these findings now?
So from a hematological standpoint, the 10 to 15% of clonal plasma cells in the bone marrow is a bit surprising. And again, it always kind of raises your eyebrows when you see a number of 10% or higher on there. But that makes sense. You know, you had a 1.2 grams per deciliter of an IgG kappa monoclonal protein in the blood. You can tell that it's definitely coming from these clonal plasma cells because these are kappa light chain restricted plasma cells. So essentially, they match the light chain that you were seeing in the circulating paraprotein. Now, that when you start going into numbers of 10% or higher clonal plasma cells, you need to start asking other questions. Because technically, this would no longer be just a monoclonal gammopathy of undetermined significance. Now you're probably in the realm of at least a smoldering multiple myeloma by definition, or doing some more clinical investigations in terms of making sure this person doesn't have any signs of multiple myeloma. But based on that, on the lab work, if wasn't any signs of anemia and the CKD wasn't that prominent on there, there wasn't hypercalcemia, that seems less likely. The FISH studies over here, the duplication 1q21, that is a classic chromosomal abnormality you'll see in about almost a third of newly diagnosed multiple myeloma patients at least. So once again, that does tell you that, it does portend some high risk in the setting of multiple myeloma. In this case, its significance is not really known right now.
Right. And Dr. Gonsalves, can you remind everyone what sort of the cutoffs you're using for deciding MGUS versus smoldering versus multiple myeloma?
Yeah, back when I was in school, it was very simple. Anything less than 10% of clonal plasma cells in the marrow, and the mnemonic that they used was the CRAB criteria, where you either had hypercalcemia or renal insufficiency due to the paraprotein from these myeloma cells, or anemia or lytic bone disease, and that would push you in. If you have 10% or higher, that would push you in this category of multiple myeloma. Now, if you don't have any of those CRAB features, but you still have more than 10% plasma cells, that would put you in the smoldering myeloma category. And then anything else, no CRAB features and less than 10% plasma cells in the marrow would change in the evidence. Now, that's changed a bit. That's actually changed since 2014. We've revised the diagnostic criteria. So MGUS still remains the same. So if you have less than 10% plasma cells in the bone marrow and no symptomatic myeloma in terms of CRAB features, you'd be called an MGUS or MGUS. The definition for myeloma, though, has changed a bit. So now, if that plasma cell myeloma percentage in the bone marrow hits 60% or higher, you automatically get thrown into the category of multiple myeloma, even if you don't have symptoms of CRAB. And part of this was mainly due to an effort to try to find patients who are at very high risk of getting myeloma in the first 2 years, that it's rather than waiting for them to get a vertebral compression fracture or kidney failure, maybe they already are myeloma and you should start treating earlier. So they've really added these myeloma defining events, which is basically the bone marrow plasma cell percentage of 60% or higher, a light chain ratio of 100 or higher, or you do a whole body MRI finding more than one marrow occupying lesion.
Those are the slim CRAB criteria now, as they call them. For that. So his bone marrow was stained with Congo red, and you can see this pinkish, amorphous eosinophilic material in the periosteal and fibroadipose tissue that is consistent with amyloid fibrils here. And the mass spec on this showed that it was TTR type amyloid deposition. So is this surprising at all, given we were sort of going down the possible AL amyloid route?
I would say no, it's not surprising, because though we have to rule out AL amyloidosis here for reasons cited, transthyretin was still going to be the most likely diagnosis given the demographics of the patient. So an older man, that's who most commonly gets transthyretin amyloidosis, particularly the wild type form. The fact that the light chain ratio itself was normal, and even how bad the heart looked, believe it or not, on echo. The fact that the EF was quite a bit down is actually consistent with transthyretin, probably because with AL amyloidosis, often by the time the heart looks that bad, patients are sicker or deceased. Now, I will say here that one could make a case that, are you still certain enough that this is the only type of amyloidosis here? Or could there be concomitant AL and transthyretin amyloidosis? There's a nice report in JACC Cardio-Oncology clinic of a couple of patients with both of those. And I would say, to my mind, as you have clear amyloid deposits, and these are pretty substantial, mass spec is the gold standard. If it did not detect any evidence of light chain amyloid, I would be okay with calling it a day here and saying this is transthyretin amyloidosis plus likely smoldering myeloma.
Yeah, absolutely. I think that's perfect. That's essentially what he was diagnosed with. We felt that there wasn't any data to suggest symptomatic myeloma. He didn't have any lytic lesions on his skeletal survey. So the plan was just to follow him, repeat labs, and monitor for progression. From a TTR standpoint, oftentimes we do like to do genetic screening for these patients. I think all your points are very well taken, that this is probably a wild type sort of clinical picture, older gentleman. This patient refused genetic screening, but that's typically, in the algorithm, you always want to further subtype your TTR into wild type versus genetic or hereditary. And we discussed tafamidis, but there were concerns over cost and just kind of the overall prognosis of this patient. He's someone who had been deteriorating over the last couple of years, and so we started him on diflunisal. And this is a figure taken out of an article that was recently published in JACC Cardio-Oncology. And, there are different staging systems for TTR, whether it be the Mayo staging system or the UK using sort of some combination of biomarkers and renal function. But I think this is a nice way and a different way of depicting sort of the importance of taking into account all your clinical laboratory imaging data when you're deciding on starting treatment with tafamidis. So Dr. Witteles, if you want to sort of comment about what your guys' approach is.
Yeah, and I would say ultimately, of course, how to proceed with what medications to take is up to the patient more than anyone. But I would have really tried to talk him into tafamidis here. A couple things. So by the most well-validated, I would say, staging system, which was published in 2018 in European Heart Journal, he would be considered stage 2 of a transthyretin amyloidosis based on his high NT-BNP, but his GFR not under 45. The average survival there the median survival was about 4 years. Now, there's obvious reasons to be a little more bearish about his survival, including his relative hypotension, just how bad to some extent his echo looked, and even his older age, 84. It's not uncommon in transthyretin amyloidosis, but it's higher than the median. But all that being said, I would have tried to point out to him just how effective tafamidis was in the phase 3 clinical trial ATTRACT, which showed a number needed to treat to save a life at 2.5 years of only 7.5, a number needed to treat to prevent one hospitalization per year at only 4.5, as well as significant slowing of progression of the decreases in quality of life and distance they could walk in 6 minutes. And lastly, diflunisal, which has some evidence in transthyretin polyneuropathy, of course, is a nonsteroidal anti-inflammatory drug. And I'd be pretty worried about using that in somebody with advanced heart failure and kidney dysfunction. Now, the issues around cost of tafamidis are unfortunately very real, and all of us in the field wish that it had been priced less than the $225,000 per year price tag that it has. However, that being said, for patients with lower incomes, they can almost all get on assistance programs that allow them to get it at little to no copay. So, you know, again, ultimately, of course, it's up to the patient, but I would have tried to really lay it out as to why my recommendation for him would have been tafamidis.
Yeah, no, absolutely. I think the cost concern plays actually a bigger role here. So, you know, you highlight really important points about sort of the overall burden from a cost standpoint of using this therapy.
Just learning points, exactly. Great.
So just some learning points for this case, that TTR amyloid is an underdiagnosed cause of heart failure. And as you pointed out, Dr. Witteles, low voltage EKG is not always seen. It's important to keep in mind conduction disturbances, atrial arrhythmias, first degree heart block, etc. And intolerance to heart failure medications is common. It's important to look for dysautonomia, neuropathies, spinal stenosis. These are all red flag symptoms. And it's absolutely imperative to obtain an SPAP UPEP-free light chain. You know, I sort of purposely put in the pyrophosphate here first to sort of highlight this point that if you had gotten just a pyrophosphate scan first, it may have biased your diagnosis. So, and it's important to realize that plasma cell dyscrasias can coexist with TTR. And this is that paper that I think you were referring to, Dr. Witteles, was also published in JACC Cardio-Oncology, just highlighting that you can have AL amyloid and TTR. And in this patient, he was diagnosed with smoldering myeloma, but we're obviously interested in following up this patient in case he develops myeloma or AL or, you know, some other more advanced plasma cell dyscrasia.
Before we move on to case 2, that was an excellent discussion and presentation by all three of you. I just want to see if Dr. Gonsalves, if you had any closing remarks about this case before we move on.
Yeah, no, I think this case was excellent in highlighting just something we deal with in our clinic all the time. We get referred patients for the presence of a multiple gammopathy, and as to whether this is AL amyloid and so forth. And I think it's important to, you know, especially with this case report, we are seeing more patients who have concurrent myeloma and wild-type TTR. You know, the survival of myeloma is increasing, and patients even with smoldering myeloma, some of them may not progress to multiple myeloma for a decade or longer. And so as they start hitting these elderly ages, 80s and so forth, they start manifesting cardiac symptoms concerning amyloid, and we always get asked the question of could this be changing? Could they be developing AL cardiac amyloid? And the last part of Rola's point of monitoring this patient from a smoldering myeloma, you know, the numbers we have for risk of progression to multiple myeloma, they change throughout. So in MGUS, we have this number branded in our heads, about 1% per year of patients with MGUS developing multiple myeloma. But actually what people forget is that it's not just multiple myeloma, it's actually myeloma, low-grade lymphomas, and AL amyloid. So, and the same thing for smoldering multiple myeloma. Bob Kyle came up with all these numbers from Olmsted County, you know, almost 20 years now. He really included AL amyloid in there. And so when you take MGUS patients or so forth, and you say, you know, your chance of ever having any problems and needing any treatment is about 20% in your lifetime or so. About 4 to 5% of that 20% was actually AL amyloid. It just gets kind of missed in the conversation.
Thank you. Thank you all so much. Such great pearls in learning and teaching